It's going to work. All right. It's happening.
It's happening.
We're here. We're here. Our planes all landed on time. So here we are. So Melissa, who do we have? It's like a special show. Like, who do we have on today?
I just want to point out that I actually prepared for this because I knew this was going to happen today, and I wanted to make sure that I didn't have something important to say. So today we have Dr. John Dayton, who is the emergency physician and healthcare entrepreneur, a clinical assistant professor who focuses on medical design and innovation, working towards advancement in digital health and emergency medicine. And he also advises health tech startups and has co-founded Utah Society of Physician Entrepreneurs. In addition to that, we have Lathe Bigler, is the Vice President of Clinical Network Services and General Manager of FDB Vela at First Data Bank, and his focus is on integrating clinical data to enhance patient care, playing a pivotal role in advancing telemedicine, medication adherence, and e-prescribing solutions. Look at me.
Oh my God. Great. That was like the most legit intro.
Amazing. Very legit.
So proud of me.
Oh my God.
We're like,
oh my God. Great job, Melissa.
Like a real podcast.
A+.
A real show.
A+. All right, so we got real stuff going on here, y'all. So we've got our news show. We got some news. We got some stuff. Allegedly, some women's health company led by a bunch of dudes, funded by a bunch of dudes, got 200 million. So we're excited to talk about that and how our lives are going to be changed when we too are reincarnated as white men. But we got other stuff going on too. So we're gonna pop our guests off, bring them back on. And Melissa, what else exciting happened before we go to our news show?
What else exciting happened? I didn't prep for that. That's not prep today.
Okay. Okay.
We have everybody on, and everybody can see everybody, and that's all that's important right now in my world. Okay.
Okay. All right. Sounds good.
At 4:30 in the afternoon on a Friday.
Here we are.
Amazing.
Okay. All right. Well, we'll move you off since, as usual, we didn't prep for this, and we will do our news show. So this is a super exciting talk show because this is sponsored by our lovely friends at FDB Vela. So super excited to have them here. They've been on our show before. In fact, I think we had them on right after the SureScripts guy at HIMSS, which was like, I feel like great timing, although we didn't actually know what we were doing there. So that was totally a coincidence. So excited to hear what Lathe has to say later on the show. But Lisa, like I wanted to start out with like real world news. I'm super excited that we got Evan Gerskovich back from Russia. What the hell? That was awesome.
And like a bunch of other people. And, you know, there's people of different minds of this one, but you know what? I think
I'm just happy to have all these people
for a country to bring people back from warring countries, prisons, and sham trials and shit. So, yeah.
Yeah, it sounded like we traded some journalists or they traded our journalists and we gave some assassins back, murderers. But I'm just delighted that they're back. Yeah. I'm just delighted that they're back. So God bless America. All right. So this I thought was interesting. This was in Politico this morning. So we had Jennifer Erickson on a couple of months ago to talk about breaking up UNOS, the big monopoly. This is a monopoly show. So the UNOS is the monopoly that has governed the organ transplant system across the U.S. And Jennifer and many other people, including members of our great Congress, did a nice job getting it overhauled. And I believe it's not decided yet, but an RFP went out to try to replace or try to find better alternatives to the organizations currently running that system. And now it has hit a snag because it sounds like the current board was, this is my interpretation, Lisa, the current board was trying to keep things cool and just move around their jobs, but keep their jobs. And they want some divorce from the government, and HRSA sounds like they are like, nope, you need some oversight. So things are happening. Well,
I think we know that was clear from our discussions with Jennifer, for sure.
Yeah, I think I'm like, this is one of those times that I'm like not mad about the government being involved, which is weird. You know, look at me, Lisa. Maybe I'll come on the next show wearing my big labor shirt. What?
Big Probably government. Not. You wear a big government shirt. Cat for big government.
Everyone will believe me. All right. Oh, AI. Lisa, you love AI. Google's trying to fix their healthcare stuff with AI. What do you think?
Yeah, no. I mean, as you know, I do think that the winners of the AI arms race, both literal arms as in military industrial complex and also as in like the metaphorical arms race in industry, is going to be won by Microsoft, Amazon, Google, and Meta. But Google's experience in healthcare, sorry, Google friends, has been a little bit rough. And I'm not sure that this will save it. But TBD, right? I mean, they will be part of like the winning, the winners of the AI arms race for sure.
Yeah, it sounds like so what they're saying here. I feel like this is like every AI tool for clinical teams is it's lacking. So all of the quotes throughout this piece were like nurses saying, "Yeah, I'm glad I checked it because there was a lot of crazy stuff missing.
It was wrong.
Like, it wasn't the best." So anyway, yeah, TBD. I think we're still pro AI doing automation things. Yay. Okay. Well, this was a funny thing that you sent me on the Twitter about our non-friends, at the Done.
Yeah.
Which is like so like epic name.
This is also like ranging on political stuff. So like, don't at me. But basically, there's a group of venture capitalists in Silicon Valley, many of whom are in healthcare, because why not? Who are pro-Trump, and a whole other group who are pro-Harris. And they are now fighting, and it is entertaining to watch from the outside as they write nasty threats at each other on Twitter. And this is one good example where one person who a lot of people don't like, David Sachs, is also connected to this this alleged Adderall pill mill done that was charged criminally. And so there's like a whole really long, like if you're looking for some deep drama that you're not personally involved in and have some time, this is a good one to read up on.
Agree. Strong agree. Also, I pulled this all through on my plain Wi-Fi, so as you can see, the great emojis didn't come through. But you can imagine they're there. Yeah, it's like some good drama. Like it turns out, people do bad things sometimes. But this is a continuation of this amazing tweet thread. Y'all should read it if you have nothing going on this weekend. You can be like, what? And it is true, like they say here, like our no one, and we actually know, Lauren on Twitter or on X. She says you can't make this stuff up. And like reading through this, I would agree.
It's a complicated story, man. So, it's like Rupert Murdoch's family and like Succession, right? Succession was absolutely based on Rupert Murdoch's family, and you can see the same drama playing out IRL now if you just read a bunch of like court monitor documents. So same thing. I'm sure there are some Hollywood people sort of reading this and mining it for the next story they're going to tell.
Into it. All right. Okay, so here's like this was the fun news of the week, and I had a lot of conversations about this. So this is so Flow, which is primarily, from what I can tell on the internet, a period tracking app, direct to consumer, has raised a shit ton of money, which according to some, because it is direct to consumer, actually this is not a lot of money if you're doing a consumer play. But the controversy here is, how did this company raise so much money? How is it a unicorn for a period tracking app? And then also it's led by the leadership team is entirely a bunch of dudes, and it was funded by entirely a bunch of dudes. Conversations about this, which ranged from you're focusing on the wrong problem, Kat, like we just need more women founders, there aren't enough of them, to like this is total bullshit. So Lisa, I am always interested in what you think about this.
Yeah, if you go back to like, and this is now I'm going to get really like, she's such a liberal, but like if you talk about like justice-based approaches to solving social ills, there's a saying that is like nothing about us without us. Usually refers to situations of like racism or racial injustice or the fight for equal rights. And like in this case, I would say I got to insist nothing about us without us. And yes, there are a few women who work there, of course, but it's interesting when you look at who gets funded, as we've talked about extensively on this show and other places. The vast majority of funding goes to male founders or founder teams with men in the founding team. There might be one or two women, but it's generally going to those groups. And it's just the differences are so dramatic. And for us to finally have some interest from VCs and from those who have capital and issues of women's health, and then to have the biggest sort of funding deal go to a team that was, founded by men and is overwhelmingly run by men, especially when we're talking about period tracking, like, come on. Yeah. And these guys also, this is the fun part though. There's an active case right now against them for selling data or putting meta trackers on, like,
there you go.
Dude. This is what we don't want.
They've been selling that data. So whoops. But apparently only Canada cares.
Yeah,
This is a Canadian lawsuit. But like,
This
not
is
great.
ridiculous.
Yeah. So I don't know. I know a lot of people have been calling to say like, what's the business model here? And, you know, I actually don't know. I know direct to consumer is really hard. I'm not surprised that they were doing some sort of data deal in order to make some money off of it. But like,
Obviously.
interesting. I'm interested to know, like, from our loyal fans, like what does everybody actually think about this? Because again, like, I talked to a bunch of dudes, I talked to a bunch of investors, a bunch of women. I think in general, like, most women are like, WTF. But I did get a lot of like, you know, we need to focus on like getting early stage founders actually out there who are women, and that's one of the problems.
And just like writing checks to women, obviously not for anything, not for a bad idea, not for shitty technology, not for something that isn't likely to be successful, right? Like all those things, right? It should be, you shouldn't just write a blank check to anyone who's like, I'm a woman founder. It has to be an actual like good, you know, founding team, good product, good idea, good traction, all those things. But like checks need to be written to those people. And I would just say in light of this, right? Like there are other period tracking and similar types of apps and services. One of them is Clue that has a founding woman team. You know, there are a few others out there. There are lots of people I know that I've met, that we've met in various places who are trying to do interesting stuff in this area. And I would just like really suggest and please ask everyone to, you know, support women teams who are working in this area. Support their products, fund them if you're an investor, right? Like this is the only way we move forward in this is we actually just fund women and really and make that happen and support them in starting businesses and starting and building new ideas, right? Like that's the only way we get out of it.
Yeah. Yeah, and for people who don't like have money, right, there are lots of ways you can help. I think Lisa and I are both involved in a lot of accelerators and other groups that help women founders out, and you can just like volunteer your time to like advise them and help them do stuff. So you don't have a bajillion dollars, like there's lots of ways you can be supportive. I will say also through some of those organizations, I've seen so many period tracker apps that I'm kind of like I don't get it. Like I like actually legitimately don't get like why this one's so special, but like I'm gonna find out. I'm here to find out. Maybe they were better at selling data to social media companies than anyone else.
That might be it. That might be
it. Who knows? Not me. All right. Oh yeah. So you sent this to me, Lisa, and like I didn't read it until I was on the plane today. And it's all about nurse practitioners. Yeah. Like not great.
Not great. Not great. I mean, you know, I think without a doubt, the US and plenty of other countries are really, really suffering with having enough, you know, strong enough medical workforce. And, you know, in the US, we had a real move to move mid-level practitioners up and have them take on more roles, including for sure in primary care, filling all kinds of gaps, rural places where people don't want to practice. You know, they cost less to the system. They certainly cost more than an RN, but they also, their scope of practice does more. In typical US fashion, like the rules are different in every state and like it's different in the VA. And so it's super complicated to keep track of. But fundamentally, this is a really worthwhile read. It's a really well-researched and interesting article from this Business Week team. And a lot of it goes into like these pretty shady for-profit colleges who are truly pushing the limits on this type of education in a way that's ultimately dangerous for people. And it's not fair to like the mid-level providers, to the nurse practitioners and the PAs who do really good work and are really well trained and like partner with physicians in different ways. It's just really, we are super cheapening this by not having unified standards, by not having like unified training and like equivalent of residency for medical doctors. Like it's not, that education is not standardized. So there's just all kinds of stuff like that in here that is super concerning. It's really relevant for health tech because a lot of health tech companies, digital health tech companies rely on nurse practitioners for a lot of things, including those in the mental health space. Like we were just talking about, done, you know, prescribing ADHD meds to like whoever shows up asynchronously or whatever, as one example. So this is a really big deal, I think. And I mean, to their credit, like physician groups, obviously they have a clear bias, sometimes perhaps a correct bias, but they clearly have been raising the alarm about this for a long time. And, you know, I think it's very much worth taking a look at this and taking them seriously. It's not great.
Yeah, and nugget from some of the other articles that come out about this, it basically the conclusion of many studies over several years is that nurse practitioners overall reduce reduce or poor outcomes in general across populations and across care settings, and they increase costs. So not great, not a great thing overall.
They increase cost as per the research that's out there right now by like ordering tests that aren't necessarily necessary in the research that's out there right now. Of course, I mean,
which they do to less experience and like less rigorous training because nurse practitioners want to make sure they got it right and all that. So interesting stuff. Kind of a bummer because this was, heralded as one of the big ways that we like changed the healthcare system. So anyway, more to come. Oh, so this is the Epic thing that came out. I only listen. I did listen to plane, so we don't have the big Epic graphic here. But so this is exciting news, Lisa, right? Because our lovely friends at Epic announced that they now have a patient access IAS type of service that it appears to be enabled via TEFCA, but also separately. If you have your own login to Epic for MyChart or whatever it might be, you can direct your data to patient apps, which is super cool. There's been a lot of confusion about this over the past couple of days that I've noticed, and that's that now the industry broadly thinks that TEFCA and all QHINs are IAS enabled, which is not true.
Wrong.
This is just
wrong-o.
Y'all.
Yeah. This is also like the first step. And so I will say that our friend Brendan Keeler and his new company are doing a little info session thingy about this. I want to say next week, because it's really quite complicated. Again, like it doesn't mean that you can like suddenly access all your data in one login, right? It doesn't mean you can look across multiple MyChart instances. There are a lot of details here. And like, I would just again say, everybody, TEFCA is super early days. Like the QHINs are going to start rolling out new services. It's going to be complicated. It doesn't mean that everything is like available all the time, right? We're not there yet. This is an important first step, but like that's also not how Epic works. Epic doesn't give you access via one login to an entire national data cloud with all your data. That's not how it works. There are different
national data. Well, at least on the Freedom Health Data Network, the
Freedom Health Data Network will do that.
We're working on that. We're working on that.
We'll post, if Brendan lets us, we'll post his thing in the thing and you can check it out. More details there. So like,
yeah. Well, yeah, he posted that to LinkedIn. I'm sure he'll let us do it. And that's via his new company is HTD. So they're like doing stuff, interoperability stuff. So we'll see what's going on. But this is actually like super cool news. Epic has done like a pretty cool thing here. So exciting stuff. And we're hoping that their QHINs do stuff. So moving on in like Monopoly news, CrowdStrike, Delta, which is my favorite company on the planet. Even though my plane almost crashed on Monday. I feel like they were really nice to me, even though that happened. But
they apologize.
They did apologize, and in addition to giving me a $12 voucher, they did refund my flight and all of my substitute flights to get me out of it. So that was great. But yeah, God bless Delta Airlines. Anyway, they're like coming for CrowdStrike. $500 million they're coming after him for. So we've got like a lot to think about here with like some of these gigantic mega vendors and like the damage they can do. So yeah, Lisa, do you think Delta will get $500 million?
If they hire David Boyes, probably yes. I mean, they're not messing around. And also like, the danger of this kind of stuff, of this like unified endpoint detection and response sort of software like CrowdStrike is like, this is just a big risk. You can't have this many big firms using the same vendor for this. Like there is really, it's not something that's appropriate to be too big to fail. All these companies that had outages need to like really take a deep look inside and say like, what could we do differently to not be reliant on one vendor? Hence monopolies.
Looking deep inside. Okay. Yeah. But I mean, some people might say some of the airlines are monopoly status, but doesn't, I do love Delta more than anything else. So that's fine. Yeah. They can be that way. All right. And then we also, this is exciting news from our friend Pooja Babra, who I think Lathe, one of our other guests, knows pretty well. So she popped over a note to us and said, will you please let everyone know that we're doing this? So Sequoia Projects launched a pharmacy interoperability work group, which is super cool. And Pooja is one of the co-chairs, I believe, which I think is like great setup for the rest of the show because it's also with SureScripts, which is also a monopoly. Like we talked about all kinds of monopolies today so far. So it's very exciting, but we're hopeful that something good will come out of this. We did see some criticism that you have to pay $8,000 to be on the work group. So like bummer, but I don't know. Everybody needs money, just like the talk show. This is like why we're in the hole, like $4,000. I mean, it just keeps getting worse every day. Lisa, what do you think
like
about
the talk shows.
Yeah. I mean, we're a monopoly basically too, right? Like everybody watches us. So anyway, cool. Yeah.
Totally.
All right. Okay.
Totally.
That's all for the news show.
Yay.
So yay. We are going to bring on our lovely friend, Dr. John Dayton. And John, can you see us?
I can see you guys. Can you see me okay?
Oh my God. Fantastic.
We can.
We might pump up your volume a little bit. Hold on. How do we do that? You got it. Lisa's got it. She knows how to do stuff. She knows how to do stuff. So John, welcome. So you are currently in Utah, correct?
Yeah. I live in Salt Lake City. I moved to Palo Alto for a couple of years to upskill and get some more education, and now I'm back home.
Awesome. God bless Utah. I feel great about that place. Okay, so when Lisa and I, like sometimes conference organizers make the mistake of inviting us to conferences internationally, and we then have to sound like we know stuff. And all of the European startups always, like the big question they always have is like, how do we avoid pilots with US health systems? Because that is where we go to die. Like, and then even in the US, people are like, great, a pilot's great, but like, how do I avoid that being the end of my company, right? It's like a great thing, but not a great thing. And so you just had an article published with some of your colleagues, I believe, about how to like get things through so innovation actually happens, as opposed to like ending up in a little mini pilot at some mega system and dying. So tell us tell us what, like, because you do a lot of things. You run like this physician investor group. I don't know what you do. So tell us the things.
Yeah, absolutely. So right now I work with Intermountain Healthcare. I'm an emergency physician there, but I'm still on faculty at Stanford. I go there every couple of months, do some shifts and work with the research team. And then I just started working with a venture capital group. And then I really like your conversation on interoperable health data. That's huge. You don't have to convince an ER doctor who's in the middle of the night with a patient that doesn't, I take a little white pill. They don't know their history, and you can't get a hold of an office, and you can't get a hold of another hospital. And so that's huge. So I'm an advisor for Zeus. I'll admit all my biases, but I work Zeus because that's huge. That's a huge pain point for ER doctors, for anyone doing, care transitions. So that's a big thing. But yeah, I would love to talk about the paper. So the bottom line is you can't escape pilots in the US system, because if you're going to get, let's say you have a medical device, right? If you're going to get FDA clearance, you have to prove that it works. And if you want CMS clearance to get reimbursed for using your tool, you're never going to get that without data. And so pilots are critical. The question is, how do you do it correctly? And so I can understand our European colleagues saying, that's where they go to die. At the same time, you have a system where you have, academic centers that want research. They want to do things that are interesting. And so that's what we looked at Stanford. We said, we're in a center. We want to use, the best and the newest equipment. We also have a lot of our faculty that people come to engage us and say, oh, be an advisor for us, help us do this thing. And we realized, let's just centralize this whole process. Let's figure out, hey, we're trying to figure out what kind of, scribe, AI scribes work best. We're trying to figure out what kind of AI algorithmic tools work best to run an ED. Why don't we pilot the things out that look interesting and exciting? Let's get some data. At the very least, let's get them some high-level physician feedback. One of the things that blows my mind is you wouldn't believe how many people come to us and say, I've spent all this money and I have this great idea and this is what I've done. It's like, oh, dude, you've got like 3 competitors and you have like people that are already like way ahead of you and they actually have data and like, oh, I didn't know this. Like, talk to a doctor super early. So that's like a big thing that pilots need to do. And then on the academic side, we're wanting to do the best thing. We're wanting research. And so that's a nice way for us to mesh. So at Stanford, we set up the partnership program. So companies come to us in the acute care space. It's out of the emergency department, whether it's a device or a digital health tool or an AI operational tool. And we kind of sit down with them. We kind of hash out a way to pilot what they're doing. We work on that together. And ideally, we either give them some feedback or we pilot what they're doing and we publish those results. And so that way, pilots aren't going to die. They're actually going to get evidence that's going to help them get the FDA and CMS clearance. And it becomes a way of them saying, rather than like, I have 3 anecdotal stories and no doctors on my board, they actually have some physician feedback. They actually have some actual data. And that's useful. I mean, you look at all the digital health funding from 2021, it was hard for these companies to cross the chasm because they were all based on ideas. They didn't.
Right.
They didn't prove that they worked. They didn't get CMS clearance, and no private insurance is going to cover anything until CMS does. And so those are like the two big hurdles you have to get to move forward.
Yeah.
That's a ton of work that I just did, but.
No, it's awesome. Also, shout out to all ED docs. Y'all are always a little bit crazy. So love that you are flying back and forth to California to continue to be an ER doc there too. That's fantastic. But y'all are always like super, super wild. So question for you about, so you mentioned like a lot of these companies had trouble, like, getting over the hump, especially as some of the froth fizzled out, right, over the past couple of years. What do you think of the Great Recession Part 2 that's happening as of today, according to all major news outlets?
The what? I'm sorry?
The Great Recession. Her obsession.
It's coming. It's
coming.
coming. The long cold winter is finally here, y'all. What did I tell you?
It's so interesting to look at that. One of the things that we were focusing on is there used to be this dichotomy, right? If you want to build something, like, well, you build it outside of the system because universities are looked as an impediment rather than an assistant tool. It's interesting to see them kind of shift, and you can innovate within your own system. But you have a lot of doctors that are like, thanks to antitrust legislation and things like that, but they're locked in an area. They're told, you have to work here, you have to do this. You're now a provider instead of a physician. And, you have to, be part of the cog. And so it's really interesting. You give, physicians an opportunity to actually innovate within their own system. You're going to get good results. And so I think things like that and antitrust will actually at least help the system for physicians. We're always the ones that are criticized. You look at the new CMS reimbursement, everybody gets a raise except a doctor. And, obviously I'm revealing my bias all over the place, but really going to cut spending while all these, VC groups are buying up practices all across the country, and hospitals that, doctors that work for hospital get paid way more, and hospitals reimburse way more than a private practice. Like, the decks are stacked against, private doctors. So it's those are all things that contribute to that.
Yeah. So, just to remind everyone here, this is not a real media outlet, so bias is welcome here. So, thank you for being yourself.
I'm biased.
Lisa hasn't worn she hasn't worn her union shirt today, but maybe next time. Yeah. So, okay. So this program with Stanford, it's basically like startups can like get their chops, right? Like, that's essentially what it is. Yeah.
But basically, you reach out to the Stanford Emergency Partners Program. It's online, and the way it works is we'll screen and talk to companies. Sometimes it's a good fit, sometimes it isn't. Things that make it a better fit are areas that are, hospitals are interested in exploring, things that match like the mission of Stanford. Also, like, if you're proposing a research project, finding out that there's a doctor there that really wants to study what you're after is a good first step. So we have Stanford's an interesting place. We have a couple AI experts on our staff. We have a couple medical device experts. We even actually have 2 venture capitalists on our staff. And so we're kind of a unique breed. And so we got a little pushback, and they said, well, this only works at Stanford. But every hospital has a quality assurance program. Every hospital has physicians interested in improving how care is provided. And so we try to build something that can be replicated other places.
Tell us what your AI experts think about AI in healthcare.
Well, so I think we're a lot of, actually, like Lisa was talking about earlier, a lot of it's operational. The big problem with
He's
AI,
he's a smart one.
It's based on the quality you put in, right? And if you have like a bunch of garbage data in, you're going to get a bunch of garbage data out. And so, while my bias is really going to show again. On one hand, well, like, it's great step Epic, be open, and you be the interoperable center. Their Care Everywhere is a dumping ground for records. Nothing there is made to make it current. Their
That's right.
Totally on siloing data. And so if they took all their tools that they had, patients would be on like 17 different meds that they're not taking. There's no effort at all made to.
There are very out of date. Like, I've had like stuff from like having strep throat, like, I don't know, 12 years ago in certain MyChart records that'll never, no matter what I do, they'll never go away. And I'm like, I don't have strep throat still. I promise. It's been 12 years.
The folks that are really good at like scraping data in Epic, you get a resident that's like can sort through data really fast, and they know exactly what to look for and how to search it. They're great, but that's like a skill they learned during residency. You take a practicing physician with Care Everywhere, and they have like 50 ADT documents, admit discharge transfer documents. They have to kind of sort through. Well, this one's from 5 years ago. Is it still relevant? Are they on any of those meds?
Probably not.
Says a surgery, was there a post-op complication? Like there's nothing in Care Everywhere that gives you any of that information. And so again, revealing my bias, I'm a fan of Zeus.
On this note, John, there was a really great episode of Relentless Health Value yesterday with Dr. Spencer Dorn. Not sure if you know him. He's a informaticist. He's really lovely. And he was really going on about like the same thing. He was saying like, his whole thing is like technology is not positive or negative or neutral. Like an epic instance is 99% in the implementation and the workflows. And you can have one that has 60 clicks to get like amoxicillin or whatever, and one that has 12. And that's a choice that you made as an organization, like in your implementation. 12 still isn't good, but it's a heck of a lot better than 60, right? Like, you know.
Well, and that's the issue, right? And then you have your implementation, and like you have to have tools. And I don't want to sound like I'm overly critical of Epic. You know, it's the best worst EHR
technology.
I mean, they're all cash registers linked to like, you know, low tech notes. That's all any of the EHRs. It's the best worst one. But I don't know. I don't mean to go off on that.
They also were saying that most the average note.
This show is made for tangents.
It
Keep
is.
going.
The average note is like as long as Hamlet or something. Like there's something just
really
stupid stat like that where you're like, what?
Yeah, it's like the patient note is like 80 pages long, right? So you look at your family practice docs who has to read the patient's history before their 15-minute appointments. They can't digest all of that. It needs to be, anytime you do interoperable, it has to be new, it has to be structured data, has to be up to date. Otherwise there's no value to it. Instead of, you know, talking to the patient and sorting it out, you're just looking at a chart saying, well, this has 3 different doses of metformin. This has, you know, lab work from 2 years ago. This has, you know, a blood pressure from 3 years ago. I mean, it's all relying on structured data. When you get into the notes, then you're looking at like your, you know, neurolinguistics programming, and but there's all these different types of AI, right? Like, so you need your CNN for the images, and you need your NLP for the chart data. And you have to have a way to kind of bring them all together and keep them all current. Otherwise, it's a total garbage in, garbage out situation.
Yeah.
So John, where do you see, so like you're like working with a bunch of startups, you're like talking to a bunch of investors, you're doing this partner thing at Stanford, you're like also a doctor. Great. So what rising category do you think is the most exciting? Like what do you see coming up that's rad?
So after bagging on AI for the last little bit, there's a lot of potential there. I mean, I'm not looking at AI from like, you know, you look at like they did, oh, you know, AI scored better than, you know, 75% of residents. And like, that's, I mean, it's interesting, but there's no contextual basis that can be misleading.
Not relevant to like actual care,
right? Like I have yet to have a patient that comes in overnight, unless they've read Wikipedia, and they come in and they say, I have, you know, mid-abdominal pain that gradually moved to my right lower quadrant, and I have rebound pain. Like nobody comes in with a classic story. You have to have your gestalt, you have to know all your things, you have to sort it out, what's relevant. But I think they have a lot of value with the operational tools. So I am excited about that. And even though I'm, you know, giving Epic a hard time on their, you know, steps that they're making to interoperability, that's going to be the ultimate thing that makes a big difference. You have people that switch their insurance, they have transition of care, they go from a hospital to a doctor to seeing a specialist. Really, the only way you can save time is if you can have a compact set of up-to-date data that'll help them facilitate that care, rather than spending the first half of the appointment like, well, this record from 2 years ago says, you know, you take this medicine and you smoke. No, I quit 20 years ago. You know, like you have to make sure you can keep things up to date. And I think AI has a way to do that. And I think operability tools will be helpful for that.
But I think we talked about this in a previous show, you know, is the benefit going to be saving money and saving time or making money? And I think all the investment has been like, we're going to make $1 bazillion. And actually the real things that are going to happen are going to be administrative and behind the scenes and saving money and saving pajama time for doctors and everybody else. You know what I mean?
No,
which one?
Right, Lisa. I think the first thing is time prevention. You figure out how to monetize it, what the value is there. So you have to say like, well, we have this many staff members. They try to collate this many records and they spend this much time getting them, rather than using this tool that'll help us do it, that'll help us save money. And I think that's how you have to look at that. The other thing is, you know, crazy enough in healthcare, people do what they get paid to do. And until you revamp it and put value on prevention, that's not going to make a difference. But now we have all these wearable tools, and now we have ways to share that data, and now we have ways to actually bill for looking at that data and you know, talking with patients about a different approach. I think that's where you're going to get your value. But until you put a monetary value on prevention, or you put a monetary value on, the time saved with technology, I think you're going to have a hard time seeing those things take the full effect that they could.
Yeah. All right. So John, tell us, well, 2 questions. You can tell us whatever you want as your closing thing, but other than Zeus, what is your favorite health tech company?
Oh, that's such a great question.
You got to pick one.
How about I just say a couple just because they're interesting?
Okay. Yeah, you can give us, yes, fine. Rattle them off.
There's a great company called Lathe that uses scraped EHR data to predict social determinants of health. It helps fuel what people are doing. It helps them save time, and it helps them anticipate problems. A lot of times I see someone in the ER and I see them a week later because they weren't able to get in with their doctor. The doctor wasn't able to see them. Information exchange didn't take place. And so they anticipate a lot of things. So I'm a big fan of Lathe. I'm a big fan of AvoMD. Yar Sepperstein has built these processes using data, using tools within the EHR to make sure they can do protocolized care, and physicians can build this for themselves without learning to code, which is a big deal. The other one I like to give a shout out to is Rocka Doctor. Bill Cherniak is an emergency doctor. He basically realized the same thing that folks at Stanford did. Well, there's a lot of doctors that are frustrated. I'm going to set up a way for them to do telehealth. Well, there's a lot of doctors that if they could intervene early on, it would save emergency department visits. And so he has a great telehealth structure that's very focused on tech. He's kind of like a darling of the folks over at Google because he's doing it in a way that's innovative. But the other thing is like, well, how are you going to do it? And you're going to bring value. And everyone says, well, CMS doesn't pay. If you figure out a way to do it and you do it at scale, like he's contracting with a whole native reserve in Canada or a whole province. And now he's in California and he's in New York. And so he's proved the ability that he can work with these groups. He can make an impact with healthcare, and he can make it profitable. And so those are 3 companies I love because they're focusing on areas where there's lots of need.
Yeah, love it. All right, John, parting words for all of our loyal fans. Because we are a monopoly. We're the only thing that anyone watches.
Absolutely.
Great.
So I would say the biggest thing, if you're a new company, involve a physician early, because they actually know the space and they'll save you so much time and money going down the road. On the flip side, if you're a company, if you're in a healthcare group or you're an office and you're wanting to improve your care, look at folks solving problems that you want to solve and give them a chance to work with your company. And I think whether that's, giving them a chance to change how you function or helping them gather data, either way, we're improving care and helping kind of bridge a gap.
Awesome.
Nice.
Awesome. Well, God bless you, John Dayton. Thank you for coming to the Health Tech Talk Show. We do owe you
John.
a narwhal image. We will execute at some point.
We're going to make it happen.
It's like a scrappy operation here, but thank you for joining us. And we will post your article again, as well as send us any links that would be helpful to startups, because, everybody watches our show. So they can find it. We'll post it tomorrow with our show notes.
I'll try them. Thanks for your time.
Yeah.
Thank you,
Thanks
John.
for joining us. All right. Now we got this guy. So Lathe. So just so everybody knows, Lathe and I actually met while he was working at a monopoly and I was consulting for a monopoly, formerly known as MDON, now known as Change Healthcare. So oh my God, like the Monopoly show. What? Oh my God. So Lathe, would you like to introduce yourself for real?
Absolutely. Thanks for having me. Well, I'm Lathe Bigler, and I have I worked at Change Healthcare. Thank you for just getting that right out.
You're welcome. No big deal.
I currently work for FDB, and I'm the general manager of our new FDB e-prescribing network. And been here about 5 years building this network. And we're just out there currently connecting with pharmacies, EHRs, and PBMs to create some redundancy. That's what we're doing.
Nice.
So we talked about a bunch of monopolies here, right? Like people talk about Epic being a monopoly. They're in all the shows that we have because it's Epic. We just saw the whole Change Healthcare United Health Group thing just totally trash physician practices. They're still recovering, and we know a lot of them have actually gone out of business. Still trashed, yeah. And then we had the CrowdStrike thing, which did affect a bunch of, I don't think anyone even knew who they were. So, people were kind of shocked, and it shut down a bunch of hospitals, and bad things happened. But there are lots of other monopolies that no one thinks about in healthcare. What do you think about them? Tell us more.
Well, I think you bring up some really important topics, because we have a problem in this market, and whether we really want to talk about it or not, we have a redundancy issue, a major redundancy issue.
We do want to talk about it. Hello, this is the Health Tech Talk Show.
We're ready,
right? So, what we see is the days where people say, "Well, that can never happen to us," or "That just would never happen." Those are happening. They're happening all around us. Change healthcare situation with CrowdStrike. And so, the bottom line is that if you're a CIO or you're a CEO and you're not thinking about the areas in your business that are single threaded and how to mitigate the risks of that single threaded, you're not doing your job. And I feel like what healthcare is on right now is a very reactionary sort of path and around, well, let's just not worry about it till it happens. And that there's a major issue when it comes to patient safety around that, and what concerns me is that in the United States right now in 2024, we're projecting to fill about 4.9 billion prescriptions.
Wow.
And what that means is that on any given day, we're filling 13 million prescriptions a day. And that's flowing unless there's an outage or a ransom, and then that stops. And the issue we have is that pharmacies can't handle 4.9 billion faxes. They can't handle 13 million faxes in a day. And so we have a major issue right now in healthcare where patients are could be at risk, and it's very scary, to say the least.
So
yeah,
Lisa, you have things.
No, I couldn't agree more. And some of these architecture decisions are things people kind of like fell into, or just like didn't build for, didn't plan for. They built for something, or they planned for something much smaller, and then they scaled and never re-architected, never thought about the increasing seriousness of problems as you become a much larger and more networked business and part of the core infrastructure in US healthcare or wherever else, right? And so, you have to stay on top of this for a long time, but redundancy is just kind of a fundamental principle of creating an always on, like, critical infrastructure service. So it's weird to me when I hear about this. I mean, I saw it too, Lathe, and but I'm just like, isn't that like how you build a thing that can't fail, is have redundancy?
So what are analogs in other, because like I actually don't know where we have redundancy in healthcare. Like, where do we even have that? But like, what's an analog in another industry?
So here's a good example. So in pharmacy, there are two pharmacy switch networks in the market. So if you're a pharmacy and you receive a prescription and you want to bill for that, there are two networks out there, and those pharmacies can usually toggle between one to the next. They could use Relay Health, McKesson, or they could use Change Healthcare and MD on Optum, I guess now, right? And so if one of those networks go down, those pharmacies are going to get paid for fulfilling those prescriptions. But from when it comes to a prescription being delivered from a doctor to a pharmacy, an actual prescription, there's only one network that is completely end-to-end, that essentially has 100% connectivity in the industry today. That means to all EHRs, to all health systems, of all practices, and then to all pharmacies, whether it be mail order, whether it be retail, et cetera. And so there's a big concern there where if something were to happen to that, there would be a significant holdup in patient care, right?
Yeah, people are still going to get their drugs, right? Like, which in many cases are life-saving things.
Yeah, I've heard about that. I've heard they tend to save some lives. I mean, I don't know about 14 or 4.9 billion of them are life-saving, but if someone's not getting their Ozempic for their weight loss goals, they're going to be pretty upset about that, right? So life-saving or not, it's extremely inconvenient too. So.
Well, if someone's not going to get their Ozempic for their, which would be Ozempic, not the other one, Wegovy or whatever, is for diabetes control. So controlling their blood sugar is in fact life and death in many cases. So that one is life and death.
Exactly.
Just to be clear.
I mean, there's like anti-seizure medications. I mean, there's all kinds of things that actually like keep people like legitimately alive. So that's real. And we did see, we heard a bunch of that with the Change Healthcare outage, we're supposed to call it the United Healthcare outage. But yeah, there were the people couldn't get their prescriptions, or they were very delayed or whatever it might be. So I mean, that was real. And I assume Not SureScripts handles a lot of that, as we've discussed, but I know that was a big problem. So a question for you, because I think about all this and the redundancy and all that. And like, if you're like a large health system, like, okay, like I get like you should be thinking about this stuff. And I also understand that many of the pharmacies in the US are chain pharmacies, but there's still like a pretty significant portion of pharmacies, especially in some parts of the country, that like, they're just like little. So, I mean, are we saying it's on those pharmacies to solve for this, even if they're itty bitty? And I mean, I'm like, feeling for the plight of the independent pharmacies here.
Yeah, no, I'm a huge advocate of independent, small independent, even regional pharmacies, right? There's so many of them that are out there that are only 10 or 15 stores that are really trying to grow.
Right.
And to say that is all their responsibility, I would probably say not necessarily, Kat. So I think first and foremost, we're trying to educate people that, hey, guess what? There is another network now. That a lot of individuals just aren't aware that, wait a minute, there is an alternative network or redundant network that we can leverage. And that's exactly why we built FDB Vela. So a lot of these small independent stores out in the country, they didn't go develop and manage their own practice management systems, right? They're purchasing some, off the shelf, typical software company to manage their daily practice, whether it's the intake of prescriptions or the billing of those prescriptions. And so it's really upon those systems, those software systems, to seek alternative sources so that they're providing their pharmacies with the redundancy that they deserve, because they're already having a hard time fighting against the bigger chains. And we work with them all. We'll work with any large chain, any small independent. And if there is a small independent pharmacy out there that did create their own software in their garage, absolutely, FDB Vela is going to work with them. So
that's awesome.
Love it.
So I have something similar about redundancy, which is a related tangent. I've been meaning to post about it, and I will eventually, but there's a really great story in the Wall Street Journal on their podcast about, and Lathe, you might know this. Do you know how many US manufacturers there are of amoxicillin?
How many?
Just one, and it's hanging on by a thread, and it already went bankrupt once. So not great. Not super. And there's a guy who was like, literally like, I'm trying to save like US manufacturing of this like very critical generic that needs, like from a health security perspective, absolutely needs to be produced in the United States of America. It's in Tennessee. I think it's in Bristol, Tennessee. And it's called USA Antibiotics. Amazing name. It's like USA Freedom Network. So,
oh my God,
just
can't wait.
Like another aspect of this, though, there's no redundancy for that, right? There's no redundancy for that. There are Chinese manufacturers, there are other countries who are manufacturing generic amoxicillin, but like not much. And having something available in the US is like another one of those examples of like where we could certainly use some redundancy. Hard to make the money work.
That's right. And I think that's the problem, and someone said earlier in the show about how the focus is on making money, not necessarily saving money, which I think is really a symptom of, our of course, being a capitalist country. And I think that there's a lot of risk to be had there if we're not focused on where are we helping save money, like the independent pharmacies that you mentioned too, Kat. I mean, one of the things that we focus on is providing better rates, to these customers so that they, as we send them prescriptions, we bring that value. But yeah, Lisa, you're right. I mean, looking for ways to save money is just as critical in healthcare as making new money in the market, right?
Yeah.
So, okay, Lisa, so, this is another example of where like, the government is involved sometimes for a good reason. Sometimes I don't like, but so FTC did kind of give a super fine to SureScripts a little while ago, right? Which is the thing. And I know they're investigating the United Health Group Change Healthcare thing, right? But so like, it kind of seemed like nothing really happened, right? It was like aggressive contract language, right? Which was what they got dinged on. But like nothing's happening, right? Like,
it's been interesting. Well, so it is happening. I think a lot of people aren't aware that it is happening. So again, a network like Vela comes into place. We're connected to several pharmacies. We're connected to several EHRs. The market doesn't know a lot about them because a lot of these players aren't willing to make press releases for reasons that they fear may cause backlash. And so we have had some partners like Veradigm, as an example, previously known as Allscripts, who did press release that they're working with Vela, which is great. But I think there's still some reluctance from the market on just jumping on board with an alternative due to fear of backlash from the other network.
Yeah, it's like wild. But like in another, thinking about just these pharmacies and like incentive to look elsewhere, right? Like, yes, there's some of that aggressive contracting language, fear of backlash for sure. And we see that in with other categories too. But is there any, and I guess this is probably something that happens when it happens, right? You don't think about it till it happens, kind of like the Change Healthcare outage, or that wasn't an outage. That was a ransom situation. But is there any evidence, I don't hear anything about SureScripts being like unstable. Is this more of a situation where some hackers might get a hold of it and they're going to have to, get a crypto account and send off $100 million? Or is this is there actual imminent risk in another way?
I hope that never happens, and I hope there never is the risk there. But I think the bottom line is we're always at risk, right? I mean, a lot of Change Healthcare was never supposed to go down or to be hacked, right? They never anticipated that. And the things we don't anticipate tend to happen at times. So I hope that never happens. What I fear is that a lot of these systems in healthcare are older systems. So let's just say this did happen. And they wanted to use an alternative or redundant network like ourselves. It takes time and development and new releases.
Yeah, you can't just turn it on the next second or whatever.
Let's just give them a call and turn them on, right? This is, right now, it may take, a few months for a system to go live on a network just based on their tech debt and, their prioritization of other items. So what we're trying to create is awareness around just connect with us. We're not even saying you have to route all your traffic through us. That's not even the discussion. The discussion is around just have connectivity to another network that can get you to the pharmacy retailers or to the hospital pharmacies or to the mail order pharmacies that your patients need to get access to.
Yeah, this is for me. I mean, I'm very sympathetic to that argument because I love competition, and also I love, I think of it from the perspective of a security issue, right? I think I know that our friends at Asper are thinking about this, and they have been doing some work in the area around the, as I was mentioning before, like the US-based manufacturing of critical drugs. Like they do work there. In this case, they, for whatever reason, didn't fund this particular factory. But like in this case, right, encouraging there to be finding ways to help support there being alternatives and being redundancy, and whether it's in a e-prescribing network or in the manufacture of critical drugs and devices, right? Like that is one of the areas where the government can be helpful, right? To make sure that we have that that critical redundancy. It's a security issue.
It really is, and I think just fundamentally at the core that's important. But what I think is even more important is when you look at e-prescribing, it really hasn't changed much in 20 years. We've added a few things, a few message types, right? But really, one of the areas that we're most focused on is innovation. And by the way, that is one of the best things about competition is when
great thing about competition. I was going to say innovation.
It drives it. You have to, right? And so from a Vela perspective, we look at it as regular vanilla e-prescribing. Yes, let's create redundancy. Let's keep patients safe. Let's do that. But also, we want to change e-prescribing. We want to improve it. There's so many better things that we can be doing. We can engage and work with patients and consumers so much better in e-prescribing than we ever have in the past. As you know, Vela was the very first national veterinarian electronic prescribing network.
Right.
So we were the first to enable veterinarians to be able to write prescriptions electronically. So, and by the way, it's no coincidence that I think it was 2 weeks ago, SureScripts announced that they're going into the veterinarian e-prescribing space. Oh, I wonder why they're doing that. So competition absolutely drives, more innovation.
Yeah, it's good.
Awesome.
It's good. It's good stuff, though. I mean, it really is right. Like that is the danger of a monopoly, as we know, is that you just say well, why should we invest those R&D dollars into like innovating and creating better solutions when we literally already own the entire market and it doesn't matter, right? That is genuinely like antithetical to what we allegedly care about here in these United States around competition and breaking up monopolies. Like, bring it back. I did try to invite Lena Khan on our show, but she did not respond, tragically.
Weird. That's, weird. We had to try. Well, so what kind of innovations are we talking about here? Because like e-prescribing is like e-prescribing.
New services, like
what's going on? Like, what are you guys doing? What's happening?
I'll give you a great example. One thing that's always bothered me about e-prescribing. Remember the good old days when you'd walk into your doctor's office and they would write you a prescription on a piece of paper, right? And you, as a patient, you left with this note. You were empowered. You got in your car and turn on your FM radio and on your way home you could drive to any pharmacy anywhere, depending on what your errands were that day, whatever, and you go get filled. And when we introduced e-prescribing, the first thing we did is took the patient consumer completely out of the process. And so where we're at today is that, in my experience anyway, when I go in and see my doctor at times, they'll write a prescription and as I'm leaving, I'm like, oh, are you going to send the prescription? They're all, oh, we already sent it to whatever pharmacy you had in your file from 3 years ago that you don't live anywhere near anymore. Okay. It's like, all right, well, it's too late. So I guess I'll just go get it. And when you leave that office, there's two things that every patient goes through. One, they hope that the script got there. And two, they hope when they got there, it doesn't cost them an arm and a leg. And by the way, this is why the abandonment rates in the United States are so high, because when that patient gets there and she gets to that pharmacy and she realizes the cost is so high, number one, she's embarrassed. She can't afford it, perhaps. And so she abandons it. She leaves it. And so what Vela is focusing on doing is we want to engage the patient immediately. And not even that, we want to enable them to make the decision after they have when they have the prescription written, they can just say, send it to me. And the prescription goes to the patient. They're then able to interact with that prescription. They can use whatever app that they want to do that. There's a lot of different consumer apps that are out there helping patients by giving them coupons, cash discount cards. It gives them information, real-time patient, pharmacy benefit information. It gives all the details of what their costs are going to be. And then they can select what pharmacy they want to have that filled at within the app. When they select it, Vela routes the prescription on to that pharmacy. No surprises. The patient shows up, receives their prescriptions, and moves on. So it's really changing the whole order and the process that engages the patient more upfront.
Yeah, and a shout out to a friend of the show, Miriam Paramore, with her new venture, RX Utility, which is around getting those coupons in a reliable way. Coupons are not like the solution for affordability, but they're a solution right now for patients being able to afford their medicines right now. Like right now today.
We're big fans of what Miriam's doing and what several others are, because they really are just looking at how do we help the patients get on the drugs and for them.
Yeah, which is really important. Like we were saying at the beginning when we started talking, like people need those medications. They are life-saving in many cases. And if they're not on them, they can't ever get better. Weirdly.
That's right.
Yeah.
They prescribe them for a reason. Right?
So what's the reason why what's the counter message here? Like, why would a pharmacy not have redundancy? Just because it's too hard to figure out? Like, what's going on?
I think a lot of it. So, and by the way, there are many pharmacies that are. We do have several pharmacies, large, national pharmacies on Vela, which we're really excited about. We have a few software vendors. But the reasons that some other pharmacies may not be joining right now. And by the way, I want to make clear, we've never had a pharmacy say no. We've never had one say, oh, we don't want redundancy. We don't want another network. It's really just a matter of priority, right? Because again, a lot of these systems, some of these pharmacy systems are decades old, and they've been written to really just handle one pipe in and one pipe out, right? So there's development involved, there's logic involved. It's not impossible, it's not too difficult, but it's work that has to be done. So I think one, they're trying to make it a priority. On the EHR side, I would say a very similar argument. Kat, is that on the EHR side, EHRs are overwhelmed with a lot of work that they have to do to meet requirements, O&C requirements, different changes coming up that they receive from state requirements, et cetera. So getting in line to do that takes time. And what we're worried about is we don't want them to take too much time, because in the event that something happens, we would just hate for any system to not be ready.
Right.
Yeah.
Right.
Totally.
Well, Lathe, what would you like to tell our loyal fans?
Well, I would like to tell them that please give us a call, and we will gladly share everything we know about e-prescribing. If you're a small startup EHR that's working in a garage that wants to understand e-prescribing and needs help, and you can't get another network to help you, call us. We will gladly help you. We will get you on an e-prescribing network so you can start prescribing. If you're a small pharmacy, reach out to us. We'll gladly help you in any way we can. We just want everyone and invite all to participate. That includes PBM systems that are providing eligibility services to providers so that they're aware of what the patient eligibility formulary medication history is for a patient. I thought it was interesting what Dr. Dayton was talking about around how important that information is to be able to access medication history, and how it's a lot of it's just garbage. And so we want to help with all those things as a network, as we have access to eligibility, as access to med history, access to pharmacies. We're just very eager to help any stakeholder in healthcare at this point.
Yeah.
Nice.
Well, and before we leave, my big things and why this is exciting and why I would love to see more innovation in e-prescribing is adherence, huge problem, right? Like you said, patients go to the pharmacy, they don't have enough money, they don't understand that you should say self-pay before you say insurance and all that. And I think any tool, any innovation that gives patients more control over how they interact in that experience is better. So we are pro competition, pro innovation over here, sometimes pro government, sometimes not. So
Gonna get Kat that Kat loves big government shirt really soon. That's gonna be
oh my God, I'll wear it.
Yes.
Yeah.
I'll wear it. Yep. God bless America. So thank you, Lathe, and thank you, John and Melissa, and whoever, all those people. So it's Friday. We got to go. It is drinking time. So not for you, Lathe, 3 hours behind.
Well, I won't tell if you don't, but thank you for having me. It's great to see you both. Thank you. It's been a while.
Thank you, Lathe.
All right.
Talk
Thanks,
to you
y'all.
soon.
Happy weekend.
Bye.